I'd like to welcome you to the North Simcoe Muskoka Specialized Geriatric Services Lunch and Learn series highlighting confinement syndrome. My name is Kim Simpson and I am one of the psychogeriatric resource consultants with SGS. Before we get going, I just wanted to go over some Zoom etiquette information. So please ensure that your microphone located at the bottom left corner of your screen is on mute during the presentation. In the bottom center of your screen is the chat box where feel free to type any questions or comments throughout the presentation, and we will allow for some questions at the end of the presentation today. Please note that we are recording this presentation, which will then be accessible through the NSM SGS website. We are pleased to provide separate sessions each day this week at 12 noon in an effort to bring awareness of confinement syndrome, this also happens to be Mental Health Awareness Week. NSM SGS has been shining the light on confinement syndrome with a communique that was released in August 2020 with a focus on confinement syndrome heading into the next wave of COVID-19. Confinement syndrome is a term that was coined by NSM SGS in response to the experiences of older adults and caregivers during the COVID-19 pandemic. Confinement syndrome reflects a constellation of clinical issues that can be linked to isolation and loneliness during COVID-19. Today, it gives me great pleasure to introduce our next speakers, Shirlene Wells and Melissa Lang, who are physiotherapists with the Geriatric Medicine Program, and they're going to be facilitating today's discussion on COVID-19 and functional decline. So welcome, ladies.
Hi, everybody. This is not mandatory education, and you don't need to be here, so we appreciate your attending this discussion today of functional decline. And it's not working for me. What did I tell you? Expect it won't work. There we go. There we go. So as you may know, the British Medical Journal has an opinion section containing comments from its community's readers, authors, editors. In June, Dr. Gray and Dr. Bird wrote a post titled "COVID-19 will be followed by a deconditioning pandemic," which I thought was sufficiently dramatic to start off this presentation. So this is an excerpt. All healthcare does harm. Much publicity is given to the contribution of poor quality care and errors, but even evidence-based healthcare delivered at high quality can cause harm. It's an inevitable consequence of the use of radiation, the prescription of powerful chemicals, interventions such as surgery, or even requiring people who are aging to stay in their homes for 3 or possibly more months. This was released in June, so we still had no idea how long we were going to stay under our isolating circumstances. We thought this excerpt might provide an interesting lens to view functional decline. So how do we define functional decline? If you look at the literature, you'll find a number of different definitions, but it basically boils down to a loss of ability to do your activities of daily living, bathing, dressing, all those things that you do in the first hour of getting up, or your instrumental activities of daily living, driving, grocery shopping, managing your personal finances, because of decreased physical and or cognitive functioning. We know that older adults can lose 1 to 5% of their muscle mass when they're not active. And we know that it takes at least 5 days of regular physical activity after a single day of bed rest. So for example, in the hospital. So functional decline results in mortality, increased deaths. We know that we have increased ER visits when people experience functional decline. We know that there are more unplanned GP, NP visits, an increased use of community care, and also the less accurately measurable indirect costs. So family, friends, the opportunity costs that they experience because they're providing crisis supports. If you attended Sandra's presentation on Monday, you'll recognize these contributing factors occurring as a result specifically of COVID, resulting in confinement syndrome. Surely you're seeing them right now, whatever your work environment is. So looking at things like less access to health and social programming. So for example, I think we have someone from VON here today. Most of you probably know the ADP, the Adult Day program, was shut down for quite a few months. I believe it's up and running again on a one-to-one basis right now. So we've got less in-person contact, less in-person assessment, fewer activities and programs happening. We know about the essential caregivers who haven't been able to get into long-term care for months and months. Those support systems have been lost for a lot of people. The staff in long-term care and in hospital are less available to provide the care. We've got staffing challenges. We've got the demands of PPE, donning and doffing PPE. People across the spectrum are mobilizing less. They're less active because they're afraid of contracting COVID or because they've been directed to. There's social distancing, reductions in the programming we talked about. So I think now is time to take a breath. That was a lot. My manager asked me last week how I was doing, and I said, well, sometimes I'm okay, and sometimes I feel like I want to scream into a pillow. So, for those of you at home, just, feel free to take a moment. Feel free to scream into a nearby pillow. You're on mute, it's okay. So how can we assess? Lots of options in community retirement home settings. We might want to ask about falls. We want to ask about their activities of daily living. So for those of you who aren't familiar with the Barthel Index, it's a measure of independence, looking at activities of daily living. Asking about IADLs, also very, very helpful. If they're not, so for example, if they are not managing their banking and financial affairs, it's important to ask, well, who's helping you with that? So if you work in hospital or long-term care, you may find this mobility algorithm helpful. You will recognize this from the SF7 toolkit. And if you didn't receive it prior to this presentation, you can just go to the RGP website and go to the SF7 toolkit. And then if you click on mobility, it'll pop up for you. So we just wanted to touch a little bit on the benefits of mobilization. I think we're all pretty familiar with its benefits: strength, flexibility, bone strength, all that sort of thing. But sometimes we forget about things like circulation. So for example, lymph fluid doesn't move around on its own. It relies primarily on the contraction of muscles. Of course, gravity massage can help with that quite a bit, but primarily lymph moves around based on muscular contractions. So just something to remember, their mobilization is important for all aspects of the body. There's not a whole lot of research on mobilization that is COVID-19 specific. There was this study published in March, and it emphasizes that mixing up resistance exercise, mixing up balance exercises is the most effective for helping to prevent functional decline. Adding the social element is helpful. So internet, radio, TV. For those of you who are working in the community and even in retirement homes, we know that not everybody has access to the internet. And this study actually talks a little bit about what's happening in Japan, or rather what has been happening in Japan for decades via the radio. So they use a radio program to broadcast a set of exercises that everybody's familiar with. Kids all the way up to older adults, everybody is familiar with these exercises, and it's broadcast at the same time, I believe, every day of the week. It's a really, really interesting idea. But the idea of making it social, making it part of your day somehow, even using media, that can be very helpful. So now we're going to talk about specific recommendations for specific populations, because as we know, everybody has different needs for exercise. And so I am going to hand it over to Shireen.
Thank you, Melissa. Okay, so recognizing the importance of mobilizing, I guess we're at a point, what can we do for our older adults? So I'm about to present some evidence-based recommendations for maximizing mobility in older adults during COVID-19. So what we've done is we've grouped them into different categories depending on what their baseline level of functional mobility was. So for this first group here, we're looking at the older adult who was, previously mobile, maybe a little more robust individual, able to leave their home. So what the recommendations are: 20 to 45 minutes of moderate intensity exercise. So by moderate intensity, we're referring to activities that will basically cause the older adult to breathe a little heavier and break into a sweat, but not become breathless. And then with these activities, or these exercises, we're recommending at least 3 to 4 times a week, and having them split up in 10-minute segments is actually common. So encouraging the individual to do exercise for 10 minutes in the morning, midday, in the afternoon is all very beneficial. It can be grouped together to create that 20 to 45 minutes that are required. So then we're talking about the types of exercise we want to see. So first of all, the endurance exercise or the aerobic exercises. So that could be simply walking, walking inside the home. If you can walk outside of the home safely, that's fine too. Stair climbing, again, if that's safe for the individual. Doing yard work or gardening, any of those type of activities. And then incorporating some balance exercises. So when doing balance exercises, I do recommend the individual have some sort of a safety net, so to speak. So standing at the kitchen counter or having a chair, the back of a chair in front of them, so they can support themselves as needed. So what they can do is practice stepping, weight shifting, they're stepping forward, backwards, standing on one leg, then practicing the other leg, or just doing multi-directional weight shifts. So, shifting the weight forward on the feet, backwards, and trying to find that midline again, and then going from side to side. And then of course, functional exercises are really important. I really like this one because movements that you do every day, such as sit to stand, can be done as a strengthening exercise. They're important. So sitting in a firm chair and just practicing that sit to stand movement, using your hands or not, depending on what the ability is. That's a really great one that I like to give people. Or just practicing stepping over obstacles. So again, maybe standing at the kitchen counter and focusing on stepping over, the idea of stepping over puddles or rocks. So they're having to do higher knee and hip movements. That's another nice one as well. And then to round it off, resistance exercises. So using resistance bands, TheraBands, or just simply some light weights, could be cans of soup, anything from around the house they can find, but doing some resistance exercises for both the arms and legs. So these exercises can be done on their own independently in the home, or there are many videos now available to follow, so they can do it on their own timeline. or they could participate in virtual class settings. So what the link you see here to the Toronto Rehab Time program, they have, this provides a great list of exercise and wellness videos that would be appropriate for people with mobility challenges of all levels. So it does give you quite a variety. And they're also put together by physiotherapists and occupational therapists at the University Health Network. And then the other option, when we're talking about the virtual class setting, our own organization has the Seniors Care Exercise Program. It is on a virtual platform at this time, being transitioned back into the in-person option. There's also a hybrid model where the person would be assessed in person and then carry out the program virtually. So there are some different options that are starting. So these are people for frail seniors. This is targeted to frail seniors, so those who are the clinical frailty scale 4 to 6. So they've had some recent loss of functional ability, but they have that restorative potential. And for this particular program, they do require medical clearance from a physician. So there are some options. Thanks. Okay, so for older adults previously unable to leave the home. So these are those individuals that are a little more vulnerable because their functional ability level was quite more limited. So basically any increase in the frequency of light activities and reduction in their sedentary time can contribute to health. So anything to keep them moving. So some of the types of exercise or movements, basically adding any movement or more movement to the activities of daily living. So such as bathing, meal preparation, housekeeping, or hobbies. So it's engaging them to do a little more within their everyday functional activities. So caregivers can have quite an important role in engaging the older adult with these movements. So another resource is the what's called the SLOT, which is basically an acronym for stretch, lift, or tap. So this is a program to facilitate keeping older adults active indoors during COVID. This is a slide just going through what the steps are to the program. So basically you just encourage the senior to make a list of the things they like to do on a daily basis, and then figuring out how they can slot more movement into those activities. So for example, getting up in the mornings, perhaps when they're getting dressed, trying to have them move their leg or arms higher before putting the item of clothing on. Or when they're sitting at the side of the bed, having them try to lift their knees higher, maybe shuffle along the side of the bed. And perhaps when they're waiting for the kettle to boil, just tapping their toes, tapping their hands to music. So anything really to get them moving more as they're just going about doing their daily activities.
Sorry.
So
did I move it before you wanted me to? I'm sorry if I did.
No, thank you. So for the older adults in the hospital with COVID-19 or other acute illnesses, basically it's the same concept. We want to get them moving, of course, once they're medically stable. So the World Health Organization recommends that mobilization early in the course of illness, of course, when it's safe to do so, can prevent further complications. So back to reducing the sedentary time by just engaging them in their everyday care. So putting on clothes, sitting up for meals, participating in their toileting, bathing, or personal care to the fullest extent possible. And then sometimes a referral to occupational therapy or physiotherapy may be indicated to facilitate this. So for those older adults in long-term care or the hospital, what we're looking at is trying to establish a care plan for them, a mobility care plan. So we kind of loop back to the simplified mobility assessment algorithm that Melissa spoke of earlier. And by assessing the individual, they're going to fall into one of these three categories. The first category in the green, you'll see, are those individuals who are able to walk, whether it's walking independently, walking with assistance, using a gait aid or not. But what you're trying to encourage for their core mobility is to continue ambulating 3 times a day or more without or with their gait aid, depending if they use one. And then there's other opportunities for mobilizing, such as participating in their personal care, getting up to the bathroom for toileting, walking to the bathroom, eating their meals, sitting up in a chair at bedside or in a wheelchair if that's what they have. And then active range of motions, encouraging the ankle pumping and moving those arms and hands. And then if you go to the next group, those are the individuals who are not able to walk, but able to transfer. So they're able to weight bear and stand up and transfer. So these individuals, again, you want to make sure they are getting up to their chair or their wheelchair and trying to get them up 3 times a day or more. And then when they're up in their chair, making sure they are self-propelling, encouraging using the hands, using the feet to self-propel if they're in a wheelchair. And just, again, engaging in all those personal care activities. So making sure they're getting up to the bathroom or the commode at the side of the bed, eating meals, sitting up, and range of motion. And then lastly, there's that group that cannot weight bear or stand to transfer. They can't tolerate that yet. So they are still encouraged to mobilize, but it's at a different level. So they are recommended to be up into their chair or wheelchair using the mechanical lift. So that's their source of mobility. So they're engaging those trunk muscles, working on posture while they're sitting up. When they are in bed, making sure that they are repositioned every 2 hours and having them participate actively in that repositioning as much as possible. And then again, it's engaging them in that personal care as much as they can to their fullest extent, and then perhaps working on standing with assistance to get that weight bearing through the legs, build up the muscle, build up the tolerance, and basically take it from there. And that's it.
Thank you very, very much. As we said, it's not mandatory education, so we're very happy. I was just, as Charlene was talking, I was kind of scrolling through to see who has actually joined. So thank you very much. There are lots of people from outside of our team, which is wonderful. We're available for questions if there are any in the chat box.
So Melissa, I will encourage you maybe to stop sharing your screen. So we go to gallery view. And I just wanted to highlight, and thank you very much, Sandra Easton Bruno has put in the SF7 mobility piece into the chat box, as well as the slot files. So for those of you on the call, you can access those files now on your computer. I didn't see any other questions, so let's open it up. If people would like to, you can use the chat box, or feel free to unmute in the bottom left of your screen if there's any questions for Melissa or Charlene. Jill highlighted, really like the idea of the slot intervention.
Yeah, I use that one a lot, and I've had good feedback from caregivers, so I do like that one for encouraging the mobility.
Abelash is asking, great presentation. Would you be able to suggest some basic assessment and care plan goals to integrate into our current VSS process?
So Charlene, I don't know if you have any suggestions. I'm curious what there is currently in terms of asking about mobility. I assume you're asking about use of gait aids and things like that right now?
I think too, you
Awesome.
offered some really practical strategies in terms of just increasing that mobilization with care delivery and those sorts of things as well. And the slot might be an option.
Mhm.
Yeah, I think as far as assessing goes, just starting with those basic using that simplified mobility assessment algorithm, that can be applied in all settings. So that's a good starting point to go from there, and then yeah, getting into more specifics. You know, whether they use gait aids, and you certainly can go from there.
Sandra's asked in the chat box, what's been the biggest challenge you've encountered related to functional decline since COVID?
For me as a physiotherapist, it's lack of internet access. It's sort of twinned. It's lack of internet access, or not having a webcam, maybe having the internet, but like having zero ability or not enough ability to do all the things we need to do to set up OTN, downloading Google Chrome, downloading the app, like all that kind of stuff, right? But also just being able to be hands-on with the person, because doing balance assessments, it's a sticky thing to do at a distance. So that's that piece. Yeah, and then the other piece is communication is really tricky when you're doing it over the phone. Sometimes when you're trying to explain to them like what kind of exercise you want them to do, it's the translation of the verbal instructions without actually seeing what you're doing. I underestimated, I think, how much people watch.
Definitely not having the eyes on. That's a tough one. Right. I agree, Melissa.
Any other questions for Melissa or Charlene? Just some thank you. So I just wanted to take the opportunity to formally thank you, Melissa and Charlene. It was great for you today to take some time and share with us. I really like what you were able to offer us, some practical tips in terms of assessment and things that everybody within the system can use, and some exercises to assist with some of those strategies. Physiotherapists are a hot commodity, and we know that not everybody has access to physio, but just being on the lookout too in terms of ways that direct care staff can try to improve some of that mobilization and when there is a need for a referral. As I highlighted, Sandra Easton Bruno has put a couple of files into the chat box, and feel free to access them there. They're readily available on the internet, so you can also reach out to one of us and we'll send them along. I also love the practical tip of using a pillow maybe for release in terms of all the challenges, because I think what you have highlighted is we've all had to pivot care, right? And we take for granted some of that in person, but there's still ability to address these important clinical issues and really try to target that confinement syndrome. So thank you to the both of you. I want to also highlight at the beginning and at the top of the chat box, I put in a file in the chat box. As I mentioned at the top of this session, we are offering sessions every day this week to highlight confinement syndrome. And tomorrow we have Debbie Lashbrook, who is an RN and PRC, talking about delirium. So I encourage you to attend that. And if you're needing that connection information, it's in the chat box, or feel free to reach out to your PRC and we can send you that information. So thank you very much, everyone.